well, it looks like we already have a good number of attendees in the webinar so far, so we could go ahead and get started. Hey everybody, thank you so much for joining for this month's AOT Learning Network webinar. My name is Brooke and I work on TAC's AOT implementation team. You'll see my colleagues Shanti, Sarah, Amy, and Jared on the screen here. And today's webinar is going to cover the foundations of E-IMR, which is Enhanced Illness Management and Recovery. It's an evidence-based practice designed to more effectively support individuals experiencing both mental illness and substance use disorders. And we are so honored today to learn about this valuable tool from the experts who developed it. So please join me in giving a very warm welcome to Dr. Julie Rohovit and Jennifer Wiseman of the University of Minnesota Center for Practice Transformation. If you have never heard of the center, you should definitely check them out. They are a multidisciplinary team of professionals, and they're dedicated to inspire, challenge, and motivate practitioners to be exceptional and effective in the recovery-oriented care they provide. Just a couple to-dos before we dive in. Registration for this was made available through the AOT Learning Network. If you were forwarded a notice for this event and are not a member of the Learning Network yet, we definitely would encourage you to join for more events like this one. I'll put the link in the chat to join in just a few minutes. And then finally, please feel free to submit questions throughout the webinar using the chat or the Q&A function, and know that we'll address all questions at the end. And with that, I am going to hand it over to the experts.
Fabulous. Thank you so much. That was such a lovely introduction. You captured us well. And we are just thrilled with the response today to all of you learning more about E-IMR. This is an intervention that is near and dear to our hearts because we did, in fact, help develop it. And we're going to walk you through it today in around 40 to 50 minutes. So this will be ambitious. Jen, do you want to go ahead and share your screen? I'll just say a little bit more about who we are and how we came about. So we are considered a center of excellence. If you want to go back to the other screen, Jen, that would be great. A center of excellence, it's hard for Midwest modesty to say that, but that's actually what the Department of Human Services here in Minnesota declared us to be and helped establish us back in 2012, because Minnesota, like I'm sure many of you, were experiencing that people just really weren't recovering at the rate that we had hoped, both in substance use and with their mental illness disorders, despite all of the different attempts, despite all of the money that was being poured into projects like the COSIG project. We just weren't seeing changes in numbers. So they established us as a center, and we really try to respond to what does the workforce need. And the very first project that we embarked on, of course, was Illness Management, E-IMR. So go ahead and forward to the next one, Jen. But just to give you a quick snapshot, this is our landing page. We do offer a number of continuing education opportunities in that spirit of trying to really identify what the workforce needs. We have a free webinar coming up on the impact of disenfranchised grief on African American communities. But what we're focusing on today is the next one, Enhanced Illness Management Recovery, which we are going to be starting a training in October. And hopefully this might inspire some of you to join us. If you want to move on to the next one. There we go. So some of you might remember that back in around 2005, SAMHSA identified 5 evidence-based practices that they were really promoting, and they developed toolkits around these practices. And we've highlighted the 2 that we were focusing on, which is Illness Management Recovery, IMR, and Integrated Treatment for Dual Disorders, or IDDT. There was a big push at a national level to train more states, agencies, and practitioners in those two approaches. So go ahead, Jen. So just as a quick refresher, IDDT is a set of really lovely, wonderful principles that are evidence-based. If we can do more of this, the idea is that we would have better outcomes. So integrated care, comprehensive services, motivational based services. I'm not going to read all of them, but notice that these are evidence supported principles, and these were really geared towards substance use disorders. So then, in parallel to that, in the mental health world, we moved on. They also were really emphasizing and doing a lot of training. I know in Minnesota, we blanketed the state with trainings in illness management and recovery. Now, this one, notice that it's evidence-supported principles and practices. So we have real strategies and skills to support people with serious mental illness, psychoeducation, behavioral tailoring, relapse prevention, social skills, relaxation training, and coping skills. And the evidence was really solid. So there has been research across the globe on illness management and recovery. You can go to the next one, Jen. And the positive outcomes with clients were that they learned more about their mental illness. It demonstrated that it minimized or reduced relapses and rehospitalizations. It reduced distress from their symptoms, and people used their medications more consistently. All very positive. However, go ahead and go to the next one, Jen. We here in Minnesota still realize that it wasn't moving the needle very much in terms of individuals who were experiencing distress. And what was missing, of course, was that many clients, in fact, this is probably very familiar to you, were presenting with co-occurring disorders. Sometimes when we ask people what percentage of your clients have co-occurring disorders, hands usually go up around 80%. I know that data will tell us that it's not quite that, but it is quite prevalent. In fact, there's a favorite quote of mine from a local psychiatrist that said, clients integrate their disorders very well. The problem is not dual disorders, it's dual system disorders. So what we set out to do, one of the very first initiatives at our center was to take IMR, which was designed for mental illness, and the practices of IMR, and the principles, those wonderful principles of IDDT, because what we heard from folks in the IDDT world is like, well, this is great, but how do we do it? We don't know how to do it. And so the how was provided by IMR. But what was missing from IMR was the ability to work with people and the recognition of co-occurring disorders. So like peanut butter and chocolate, we brought two really good things together and made them even better. And so we worked with, some of you might be familiar with these names, Kim User and Sue Gingrich and Lindsay Fox, and we brought the two together to create enhanced illness management and recovery. And some people call it IMR4 because it really is the practices of IMR, but with the principles integrated from IDDT. So go ahead and move forward, Jen. People will ask us, well, who is E-IMR intended for? And in terms of individuals and clients, it is people with serious mental illness or people with serious mental illness and co-occurring disorders. Just because we've integrated substance use disorder doesn't mean that people have to have a substance use disorder, but if you scratch the surface, probably many of them do. So it does address both. And in terms of practitioners who can use it, it's across the spectrum. Peer support specialists, mental health practitioners, both licensed and unlicensed. We've worked with nurses, psychologists, psychiatrists, and even we're working with several groups where we're even doing an introduction to E-IMR with all of the clinic employees. So people at the front desk, people who are working in the kitchen, people who are on the night staff. So they all have a shared language around goals, recovery visions, and just recovery orientation. And Jen, one of our lead trainers, and really has done a tremendous job of helping develop our E-IMR training, is going to dive into the meat of things with you.
Wonderful. Hi, everybody. My name is Jen Wiseman. I'm at the Center for Practice Transformation, work closely with Julie. So, let's move on. We're going to talk a little bit about the underlying values and principles of E-IMR, which you might recognize from some of the principles of IDDT and IMR2. But we really work at eliciting a sense of hope for our clients. We know that most often people who come in to receive services and treatment are feeling hopeless, right? And so we really work to help them develop a sense of hope. And that really happens right off the bat in E-IMR in our first module. And then we understand that the client is the expert, right? We might have a degree or some letters behind our name. It might be the expert in certain things, but we are certainly not the experts in other people's lives, right? And their experiences. So we let the client guide us in helping us to understand what their experience is like. And then we emphasize personal choice, right? We want to develop a sense of autonomy for the people that we work with, and we strive for a collaborative relationship. And that is something that we do in everything in E-IMR. It's working with our clients. We're never giving them stuff to do on their own and, bringing it back to our office. We're working on things together in session. And then, of course, demonstrating respect as priority and a value in E-IMR. So the practice principles then in E-IMR are these 6 things that, again, recovery is defined by the individual, and that the stress vulnerability model provides a blueprint for illness management. Many of you might be familiar with the SVM, as we call it, or stress vulnerability model. And we really seek to understand how a person's maybe biological vulnerabilities or just vulnerabilities in general might interplay with the stress in their lives or their environment, right? And how that develops or turns into mental illness and substance use disorders, not just the development from, but we also look at it from a recovery perspective too. So how those vulnerabilities are actually strengths, and the experiences in their lives and the people they're connected to really can help to shape their recovery as well. And then education about mental illness, substance use, and treatment is the foundation of informed decision-making. So there's lots of psychoeducation that happens in E-IMR when we work with people. And what we're hoping is that people are able to learn more about their diagnoses and their symptoms and themselves in general, so they can make better decisions about their care and just their lives in general. And then there's collaborating again with professionals and significant others, helps people to achieve their goals. And so that really is a focus on connecting people with important resources and community members. Maybe it's peer support specialists, maybe it's employment support, right? We're just wanting people to get as connected as possible, and we're helping them to do that throughout E-IMR as well. And then, of course, relapse prevention planning. That's another principle of IMR, right? That relapse prevention helps to reduce relapses and rehospitalizations. That shows up really in Module 10 in our manual, where we focus on wellness and developing a plan for staying well, right? As people move on into their recovery, and help them learn and use tools to support their recovery. And then finally, individuals can learn new strategies for managing their symptoms, coping with stress. It's really that hopeful way of looking at working with folks who might feel loss of confidence and self-efficacy, right? That we help to elicit that and nurture that so they can learn new ways of moving forward in their lives. So those are the principles and values that underlie E-IMR. So we thought we'd put a client experience in here because we thought this sort of encapsulates much of what we see in the work that we do with people in E-IMR, but one of our clients was kind enough to provide a quote here for us, and that they really liked the worksheets. Actually, it was something they referred to even after treatment and the things that we did in E-IMR, and then having that material and understanding and working through E-IMR helped them to understand that each person is multifaceted, right? So it's this individualized, integrated approach to care where we're knowing that people have different paths to recovery, right? And we respect and honor that, and that everything is intertwined. So a person needs to be treated as a unique person who has their own journey into recovery. And I love this, we're more than just a singular diagnosis, right? So E-IMR is great because it gives us this really flexible way of working with people to recognize that and to work with them along the way to provide a really person-centered, individualized approach.
Hey, Jen, I'm just going to jump in really quickly because I meant to mention this earlier, and it does fit kind of nicely here because, we put out, Jen talked about the principles for E-IMR, and this client experience is sort of bringing those principles to life. But we did do a pilot when we first developed E-IMR and ran it in 2013 to 2016 with 6 different sites, some rural, some urban across Minnesota. And the client outcomes was statistically significant, say that 10 times really fast, and showed improvement. I'm going to list these off really quickly and in the following areas: progress towards personal goals, recovery knowledge, involvement of family and friends in their care, symptom distress, improving functioning, relapse prevention, relapse minimization of symptoms, fewer psychiatric hospitalizations. They were better coping with their illness and better with functioning that had been affected by their alcohol use. So just wanted to share that. Thanks, Jen.
Yeah. Great. So when we talk about recovery, because we talk about it a lot, we're posing a question to all of you. And that question is, how do you define recovery? And so feel free to put it in the chat as we go, and we'll keep track of that. We might not be able to get to everyone, but we know that recovery is pretty personal, right? And so we're interested in understanding how you define recovery.
Jen, I'm not seeing anything coming through right now, so I'll be paying attention. Why don't you? Oh, there we go.
Recovery is if you say it's recovery. Yes, absolutely. And yep, engagement in treatments and support to reduce symptoms and improve overall well-being. Yes. Personal journey.
It's a process. Yes, yes, yes.
Yeah. Daily process even. Yep. Mm-hmm. Yes, these are wonderful. Working to change the things to improve oneself. Yes. And that directly aligns with, we provide an example here, and you can keep adding to the chat. Recovery, as defined by SAMHSA, is a process of change. So we saw that show up in the chat, a process for sure of change, and change is a big part of that, through which people improve their health and wellness, live a self-directed life, and strive to reach their full potential. Whatever potential that is, right? And so as we see from the chat, it's deeply personal to each of us. And it's something that is also deeply personal to our clients. So also think of the term recovery, right? And it is actually kind of, the word itself means that we're recovering something. And oftentimes when we're working with people in recovery from mental illness and substance use disorders, it's really learning to live a completely different way than they had before. So, I work with clients often who will say it's a personal wellness journey, or, there's lots of different ways to describe recovery, and it's not just substance use, right? We talk about it as just this in this holistic way from, we're all in recovery from something, whether it's an illness or a broken arm or loss of a loved one, right? Recovery is deeply personal, but a process of change for sure. All right, so we will move into talking about having a recovery orientation. So we know a little bit about like what we think recovery means to each one of us and what SAMHSA says. And so when we think about sort of this recovery orientation, we go back to understanding what a clinical orientation means and the difference between a clinical orientation and a recovery orientation. And so from a traditional clinical orientation, it really assumes that the providers are the experts, that we are the experts and we're here to tell you what to do to get better in your life, right? And it expects that clients adhere to treatment expectations, compliance, you hear a lot, adherence to expectations, those sorts of things. And there is a focus on symptom reduction. Makes sense, right? That's why people are receiving treatment. They need some help with their symptoms. But what we know is that clients are much more likely to engage in treatment with us when we work from a recovery orientation. And that is the foundation of E-IMR. So in enhanced illness and recovery, illness management recovery, we're really working from that recovery orientation where the person is the expert. Our clients are the expert. This movement emerged from the recovery movement in the 1960s and 70s. Right? Where there was a focus from this serious mental illness, doom and gloom, hospitalization sort of standpoint to potential for healing and recovery, and that we are more than just our illness. So in recovery orientation, we focus on our clients' wants and needs. And so that is E-IMR. And so we can see here from the left and the right here, right? We're looking at on the left clinical goals, and on the right we have recovery-oriented personal goals. And on the left, there's that clinical orientation where we might see that a person would benefit from safe housing, to be free from fear, to be substance-free, to get treatment, to attend treatment, symptom stability, to be contributing members of society, right? And on the right is really what we see often that's important to people. It's what's important to them. They want to become a part of the herd again. They want to find a partner, have meaningful things to do, have places to go, rituals to be valued, to have some independence and things to have, and so on and so forth. These are just some ideas, right? And we know that oftentimes our clients might come into care and have those clinical goals as a priority. They might say, I'm really wanting to cut back on my alcohol use, or I really want to quit using fentanyl, right? And that's great. So people might have those sort of clinical ideas or goals in their lives. The moral of the story is that those recovery-oriented, the person's goals are the leading and driving force in everything that we do in E-IMR. So sometimes there is overlap, but we let the client's idea of what's important to them guide the process.
And I'll just jump in here real quick, because sometimes they're not interested in clinical goals. And that is oftentimes, you as the professional, as the practitioner, kind of know that, well, they're need to do that for their well-being, for their health, for their welfare. They really need to engage in that. But the way that you can get there is by focusing on what's important to them if they're not ready to do those, align with the clinical goals yet. And the important too is the path or the doorway that opens to the clinical goals, because eventually they're going to need to address those to get what they want and to be able to make progress towards what's important to them.
Mm-hmm. Exactly. Yeah. Thanks, Julie. Okay, so we'll talk a little bit about recovery, then recovery vision in E-IMR and how it shows up in the actual intervention. And so module 1, and so Julie and I have these E-IMR manuals, and you might see like it's kind of big and it's used, but it is, chock full of tons of activities and things that we can do with our clients. And it seems intimidating at first. It's just a larger manual. However, it's meant to be used really flexibly. It's only module 1 that needs to be done in order with our clients. And that's really where we're understanding their definition of recovery or wellness or however it is, what they want to do, right? Defining their own recovery both like just in general, but even outside of treatment. And that can be really inspiring for a lot of people that we work with. So in module 1, again, we have these principles that come up. The client is the expert. It's collaborative, and this module 1 really helps to elicit a lot of hope and excitement in the people we work with. And in module 1, then we really work to define a person's vision for recovery. We call it a recovery vision. And this is the golden thread of what guides the work that we do in the E-IMR manual. And so the recovery vision is really what's important to us. It's steeped in our values. It includes lots of different areas of our lives. It might be work, relationships, hobbies, etc. And what we know is many people who come into E-IMR with us have this really good idea of what recovery looks like to them, or they might be able to define that right away. And for others, for whatever reason, maybe it's they have, really significant symptoms. They might be experiencing withdrawal. Maybe they're just feeling really dejected or not in a place where they want to talk about a vision for recovery. We do activities and creative things around that to help elicit some sense of recovery too. So just some examples of what we might do. And these, I should mention, in E-IMR, it's meant to be used both individually and in groups. And so when you're working with someone, you can do these same activities in a group. As many of you who've done group work before, it's just kind of a different beast, and it can be really fun and really motivating when you're working with clients doing E-IMR in a group setting too. So here's some activities. You can do journaling, arts and crafts, meditation or visualization, timelines, a daily log. We ask a lot of open-ended questions for people to get at what do they see for themselves outside of treatment or their vision of recovery. Right. So as we move through that, right, and we work to elicit that recovery vision in module 1, we also are understanding people's stages of change. Is anybody familiar? I wish I could see your hands, but familiar with stages of change? Many of us are. The trans-theoretical model of change. It is a model that, for me as an early practitioner, really changed the way I work with people. So in understanding a person's stage of change, we know then how to apply what we're doing with them, right? So if a person is in an early stage of change and not ready to make any changes, that we're not going to push, right? We're not going to continue doing activities and worksheets and things. We're really going to focus in on engaging with them. And then we have the stage of recovery too, which is steeped in the recovery movement as well, with lived experiences of people in recovery. And those are the stages they go through that are emotional and psychological as they move through recovery. And we have this cute little graphic here. I love this. It's what people think recovery looks like. It's so nice, neat little arrow here. And most often what it really looks like is kind of a mess, right? There are peaks and valleys, and it's not always linear. Sometimes we encounter patients or people who are in a pre-contemplation stage of change one week, and the next week they're in action state of change, and then the following week they're back to pre-contemplation. And the only thing I'll add here too is that we get really good at recognizing a person's stage of change, not just as it relates to substance use, right, or their mental illness, but that they might have a different stage of change for each behavior, right? They might be in an action stage of change around finding a part-time job, and a pre-contemplation stage around reducing their substance use. And I'm noticing a question came in here. Can a person with, so significant anosognosia use the E-IMR system? And yes, we have clients that we've worked with who experience that. And the answer to that question is that we just move at our client's pace. It's part of what we do in E-IMR. We chunk information, check for understanding, and just move as slowly as a person needs, recognizing that stage of change along the way. So I hope that helps. So here in its entirety, we have stage matched care And on the left here, we have the stage, and then in the middle, we have treatment, and then on the right-hand side here, we have recovery. And as I'd mentioned previously, these stages of recovery were based on research, people in the recovery community talking about how they felt and what they were thinking throughout their recovery process. And they aligned pretty well with the stage of change and treatment. So you might often notice people coming in and just be able to recognize almost the stage of recovery first before you even can identify a stage of change. So often the stage of recovery can guide our identification of a person's stage of change. And so we know that when people are in pre-contemplation, right, they're maybe not recognizing or understanding a need to change. And so we engage with them, get to know them better, right? And we don't sort of do activities and things that you would do in an active stage of change for that person. So in the interest of time, I don't think I'll go through each of these, but we do recognize this stage match care for people that are working in E-IMR. So what do we do then? Like, we understand the stage of change. We have this manual. And so we have these practitioner skills that support recovery. And this is really under the principle that people can learn new strategies for managing their symptoms. So these skills are really meant to enhance a person's understanding of their own experience, their diagnoses, their symptoms, and within the hopes of being able to better manage them, right? And so those skills are motivational, educational, and cognitive behavioral. And we will mention here that you don't need to be an expert in motivational interviewing or be like a Mint trainer, right, to do motivational skills with people. They are inherent to the E-IMR manual. So as you move through the E-IMR manual, these skills just show up and you're doing them with clients as you move through the content. So the motivational skills that show up are promoting hope and positive expectations, connecting information and skills to personal goals. We explore the pros and cons of change, and we hope and help people to reframe their experiences in a positive light. And cognitive behavioral skills steeped in CBT theory, right? We have these skills that show up that are reinforcement, modeling, role play shaping, behavioral tailoring, which is just a fancy way of saying exploring a person's environment and just adjusting it to hopefully support their behavior change. Behavioral tailoring, cognitive restructuring, coping skills, relaxation training, and social skills, which you probably remember from the beginning too as part of IMR's principles too.
And I just want to jump in and mention something as you're talking about, especially it came to mind when you were talking about how the manual is designed, and you don't need to be an expert in MI to be able to use the motivational enhancement skills that are really built into E-IMR. So if anyone used to do IMR or is still doing IMR, you probably remember that there is the client manual and then there's the practitioner manual. They're both very large, but they were separate. So when we were designing this, we actually created one manual to be used collaboratively together. And that was very, very intentional. And we actually worked with clients to get their input on the design and content, some of the content as well. So that's why it's very, very interwoven, very collaborative throughout. So I just wanted to make note of that as Jen is sharing more about the manual.
Yeah, and you can also, if you're a Mint trainer, if anybody's out there, you can still do E-IMR too. So yeah, so you don't have to be an expert in each, but these are the skills that show up just throughout each module. And finally, we have educational skills where, again, collaboration comes up. We focus on interactive teaching, and just naturally, the E-IMR manual does that. It encourages sharing experiences and stories from one another, and there are stories built into the manual, encouraging completion of try-it-outs and home practice. Chunking, information, and checking for understanding are two big skills that are naturally just built out in E-IMR, where we take a minute to stop and just check in with someone and make sure that they're understanding what we're working through, and then chunking the information into small bits too. So here we'll get into a little bit of the E-IMR manual. And so we'll just give you a quick overview here of what the E-IMR manual is and what it includes. Here we have the table of contents, which has all the different modules here. Again, module 1 is all about recovery. 2 and 3 are really about psychoeducation, practical facts. The SVM shows up in module 4, and a fan favorite is coping with stress. For module 5, we got building social supports, using medications effectively, and so on and so forth. Module 10 here is where we have relapse prevention. It's developing a plan for staying well. And then finally, getting your needs met in the healthcare system. So those are the different modules that are offered. And again, meant to be used flexibly. Thank you, Julie. And at the front of each module, we have a brief introduction, and there's a bunch of questions to get us started. So it's super nice with clients. It kind of gets the juices flowing, for lack of a better term. You get to talk about like what this might mean and get them primed and ready to be able to talk about the topic. And for each session, we always encourage to set an agenda. It's just a nice way of reducing anxiety for us and for our clients, and set some expectations and parameters around time, right? And what we're doing during our session. So these are the components of an agenda in E-IMR. And then we have activities in each of the modules, and they've got these cute little like icons here that help you to identify where they are in the manual. And so we'll go over each of those just briefly. We have let's talk about it activities. It's a little call out button where there's discussion questions again for, encouraging deeper conversations. Make it your own activities show up a lot. That's where most of the worksheets are in E-IMR, and they're fantastic because it allows you to move through content with your client, and then your client is able to reflect and sort of map what that means for them, how they relate to the material. They make it their own. It really makes the content of E-IMR come to life. We have tried out activities in E-IMR, which is another term for role play or real play, if you will. And it's what we call skills practice in E-IMR, and it helps to guide clients through behavioral rehearsal. So this skills training and try it out is our way of practicing in session with clients, so they're much more likely to do it outside of session or outside of care or treatment. And it shows up starting in module 5, coping with stress, and it shows up all throughout the rest of the manual. It draws on those motivational, educational, and cognitive behavioral skills, and it really helps people to do in session and then be able to do outside. So I've got some examples here just of the many try it out activities here that you get to try with your clients. And so we see relaxation skills like relaxed breathing is a really fun one to do that people really like. There's starting a conversation, which can be really hard for many of us. So we practice starting conversations with our clients, coping skills, and then relapse prevention training we also do there too. So just some examples of what shows up in the manual. And then finally, we have goal tracking. And so goal tracking really is kind of the core of how we map everything out in E-IMR and the work that we're doing with clients. And goal tracking shows up with this little check mark icon here. It really helps our clients work towards their goals and generate a sense of motivation and self-efficacy too. This is what the goal tracking sheet looks like. It shows up in module 1 in the manual, and it's where, once we define that recovery vision with our clients, they are listing it out here. If your client is not a worksheet person, we're flexible, right? We don't use worksheets with people who don't necessarily want to use worksheets, but this is a nice way for people to have a tangible idea of what they're doing. Then strengths, recovery goals, how you're going to get to that vision, right? People who can support, and then we break everything down into objectives and steps to help reduce anxiety and make goals more tangible for people. Because, behavior change is hard, and getting to a final goal can be really hard to conceptualize when they're not little steps built out underneath that. So we really work to do that with clients. And so that goal tracking sheet is similar to a clinical treatment plan. We hope that the two overlap or are the same. We understand that many of us have guidelines around documentation and that sometimes it can't be exactly the same, but we know that if we use the goal tracking sheet to inform that clinical treatment plan, it's going to be much more person-centered for people. And here we have another quote. This time it's from a participant of E-IMR training who really loved the goal tracking sheet and had a great experience with using goal tracking with clients in E-IMR. It does really help to motivate people when you can check off those tiny steps along the way. It's really fun to take time to celebrate that and generate some excitement. Then we have home practice, and home practice is something like if we learn a skill or we practice a skill together, we're connecting that to what a person can do outside of our session. So we set a home practice. It's part of the agenda. And it helps clients generalize the work they do in sessions. And we always hope that home practice can be part of the goal tracking sheet. And here we have key points. They're just a little pin here. It chunks the information and really summarizes the main points. You see that all throughout the manual. Recovery corner is my favorite. It has those personal stories of people in recovery, and it helps people to really identify and feel inspired by people's stories. And that also is through the E-IMR manual. And so we'll move through just some important worksheets here. I know we're kind of coming up on time. You already saw the goal tracking sheet. We do have what's called the Satisfaction with Areas of My Life worksheet for people who might not be ready to do or develop or elicit recovery vision. Really is a way for us to engage with people too. So if people are in pre-contemplation, it helps us to get to know them better and their experiences, what they're satisfied with or not satisfied with, and what their hopes are for the future. And it really helps to guide what you're doing in E-IMR too. So that's the Satisfaction with Areas of My Life worksheet. And then we have a step-by-step problem-solving worksheet, great for barriers when people come up against barriers in achieving some of those steps or objectives. It's also great for people to be able to look at pros and cons of change or an issue, especially for people who are used to living in survival mode, right? Or maybe used to making like gut decisions, that you can map it out together and understand what steps they might want to take. And then we always recommend that people follow up on goals. It's an opportunity for us to address barriers, to just celebrate even the tiniest successes, and really kind of get a feel for, is this something that a person really wants, or do we need to shift gears a little bit and identify a different goal? And finally, we have behavioral tailoring, which I'd mentioned previously. It shows up in Module 7, where we're talking about medications. And we're helping people identify ways in which they can support their medication plan and have conversations with their prescribers and set up their environment at home to help them remember to take meds at certain times of the day. So we do that to help people in that too. And then relapse prevention planning, again, shows up in Module 10. And, we know that relapse is common. We want to help to minimize a person's, chance for relapse. And in E-IMR, we really kind of wrap around them and help them to get some planning in place and some skills in place to hopefully mitigate any relapse moving forward and practice those skills we learn along the way. So, Julie?
Yeah, we just wanted to share, we'll get to your questions in just a few seconds here, but, we originally developed this, not really thinking a whole lot about what might happen with it, focusing mostly on Minnesota and working with Minnesota's ACT teams, behavioral health hospitals. And then we were really surprised to see it take off, which we think is fabulous and welcome. So the green stars are where we have provided E-IMR training across the country into Canada. And then you see a star that's way over there in the ocean. And that's because we actually had somebody join us from Africa for an E-IMR training. we've done a lot of work, particularly and interestingly, in Oklahoma and New Hampshire. New Hampshire's DHS sponsors several trainings a year because they want all of their practitioners to be utilizing E-IMR. And if you're from Minnesota, you may have, and working in an ERTS facility, it has become established as a licensing requirement and program licensing requirement that E-IMR is utilized as a foundational approach to supporting folks. We've also done a lot of work with the FSP teams, which are the adult full service partnership programs in California, Los Angeles or Orange County in particular. I call them ACT Light. But we've worked with inpatient, outpatient, residential programs. There's a wide variety of programs that have adopted E-IMR. You can move to the next one, Jen. As I mentioned earlier, if you are interested, we do have E-IMR training offerings. We can come to agencies. We also will do virtual trainings. We have our introduction to E-IMR, which is an on-demand three continuing education credits. And that is actually folded into E-IMR foundations for people who want a larger, longer experience with E-IMR. We have an asynchronous version that Jen was instrumental in developing, which is new, that people can do just on their own time. We know that practitioners are really busy. But if you would like to join us, we do offer live virtual. We meet for 5 weeks in a row, 3 hours each time we meet. And we have folded consultation into those workshops because what we found is that we go over some of the skills and strategies. We encourage people to practice those in the week in between and then come back and we have consultation and then learn new skills and strategies. And we offer those quarterly. I think our next one is up on our website and starts October 16th. And as I mentioned, we've trained full agencies as well. We are developing an E-IMR certification ladder, and we also do fidelity reviews. We recently worked with an ACT team that was a brand new ACT team, and they wanted to launch their program from the get-go using E-IMR. Unfortunately, COVID wreaked a little bit of havoc with the big grand plan, but we were able to do virtual training with them, and Jen was able to go and do a fidelity review and do some booster sessions with them on site, which was really great. I think we are ready for questions. Jen, I'm going to read this one and let you take it because it's a good one. It's a head scratcher. Who does E-IMR not work for?
That's a good question. The research really supports, the use of IMR-based practices for people with serious mental illness, so schizophrenia, bipolar disorders, and major depressive disorders. Over 40 RCTs have been conducted in IMR, focused really on SMI, but does really work for people across cultures, and also for people experiencing maybe generalized anxiety disorder, those sorts of things, right? But what we don't know for E-IMR, we really, there's at this point in time, because our research on E-IMR is fairly limited, work for people with, experiencing people with autism, right? People, we just don't know. We're just not sure, right? We try E-IMR with everybody. It's not generic, but components of it can be applied across like conditions or people in general. But again, the research is fairly limited to people with SMI.
We have used it. Oh, I was going to say in two correctional settings. Which was a little more challenging. In one correctional setting, these were folks that were there for life. And so goal setting was quite different. But still doable. It just had to be adjusted to the reality of their situation.
Mhm. Yep. And much of the research that we have now actually is all with adults. Maybe Julie might speak to working with teens or adolescents in E-IMR.
Well, we're in the process of, there's a team of folks here at the University of Minnesota that are in the process of adapting it so that it's developmentally appropriate for youth and adolescents. So we hope that we're kind of in a funding glut at the moment. We're hoping to find out in the next 2 weeks whether we get another round of funding to finish it. But it will definitely have the flavor of E-IMR and a very interactive manual. We've got all of the chapters fleshed out. We just need to be able to finish it. So there will be a youth version soon. Well, soon. Coming.
I hope that helps answer that question.
Yeah.
I was going to say you guys are making my life easy with your question facilitation. I just wanted to do, first of all, thank you so much. This has been so informative. And I wanted to do, I put it in the chat, but a last call, everybody, for questions. And we did get one about Yvette is asking about what about patients with psychosis?
Mhm. Right. So people experiencing active psychosis or active hallucinations, it really depends, right? We want to make sure that our clients are able to connect with us and the material, right? So they're in a place where they're somewhat stabilized and they can have conversations because it is, as another participant mentioned here, and using the former IMR manual, yes, it is a bit dense. There is a lot of content. I always ask that people really take the time to understand their client's perspective and chunk the information and check for that understanding and piece it out as much as you can. Sometimes I've spent, there have been times that I've spent, 2 weeks on one topic in E-IMR, and that's okay. So yes, with a caveat.
Thank you. And I think we have another question about co-occurring borderline personality disorder, and I guess how and if EIMR is effective for that, how would DBT fit in?
You know what, the way we look at E-IMR is that it is a wonderful framework and you can integrate other practices with it. You just want to make sure that the principles and the spirit of your approach align. And so always having that recovery focus, always, really framing things around that, but certainly you can integrate DBT as appropriate and as needed by the individuals you're working with.
That makes sense. Thank you. I think those were all our questions, unless I am missing any. Thank you, Amy, for putting the center's website in the chat.
Well, we would love to work with folks from Louisiana. So help spread the word, Janet. We're ready for you.
And Iowa, we welcome all. Can add more to our map.
As an Iowegian, I would love to work with people from Iowa. That would be terrific.
Well, amazing. Thank you all so much. And for everyone who's on right now, you all will get a copy of this recording so you can revisit the presentation and the slides and yeah, give a round of applause for our panelists.
Thanks everyone for coming.
Yeah, thank you so much.
Great one.